Hello, everyone. Good morning. Thank you for joining us for this session on the AMR tools and resources. It's an introduction for health professionals and researchers. My name is Isabela Cabrera, and I will be chairing the webinar today. This webinar is brought to you by the Global Research on Antimicrobial Resistance Project, or the GRAM Project, and hosted by the Global Health Network here at the University of Oxford. This session is intended to introduce some key resources to support health professionals and policy partners working on understanding AMR. GRAM is a partnership between Oxford and the Institute for Health Metrics and Evaluation at the University of Washington, and it is supported by the Department of Health and the Wellcome Trust. We will firstly be covering some housekeeping details before we begin the session. Just firstly, I wanted to let you know that the session is being recorded, and the recording will be shared in the coming weeks on the TGHN platform, so you can review and share the materials. These materials can also be found using the links that are just being shared or about to be shared in the chat. Please use the chat feature for the introduction or to report any technical issues. You will be supported immediately by someone from our team. And to interact with the panel, please use the Q&A feature to post your questions and comments. You can do that anonymously. Your video and microphone have been disabled due to the number of participants, and there may be an opportunity at the end of the session to ask questions, but since we have so many people joining today, we might not be able to cover them all. You can post questions throughout the session on the Q&A chat box, and we'll try and get through as many questions as possible. This is just a quick heat map so you can have an idea of who is joining us today and from where. And we'll then cover really quickly the panel and agenda before the first presentation. So we're going to start with an introduction to MICROBE, which is presented by Rachel Latuco, which will cover an overview of the platform, a demonstration of key functions that are relevant to the AMR research on a country level basis. Then we will follow with an introduction to the WHO GLASS data presented by Dr. Esther Van Cliff, and the AMR Data Repository presented by Dr. Barney McManagle, which will cover the background and the purpose of the repository and the current curated data sets and access pathways. And then we will end with an introduction to the AMR package presented by Anna Nevikova, which will cover the core analytical functions and some examples supporting surveillance and modeling work. And lastly, we will have a 25-minute Q&A session, which will be moderated by Professor Ben Cooper. Then we can, I think that's it. We can go ahead. Rachel, if you want to go next and share your slides.
Thank you, Isabella, for the introduction. I'll just go ahead and share my screen. Hi, everyone. My name is Rachel, and I'll be giving you a brief introduction to the MICROBE tool. So here's the outline of my presentation. I'll just start by briefly telling you what MICROBE is, how to find it online, and then show you how to explore different estimates for infectious syndromes, pathogens, and antimicrobial resistance using different figures available in the tool. And then I'll end by showing you how to download data from MICROBE. So MICROBE stands for Measuring Infectious Causes and Resistance Outcomes for burden estimation. It's an interactive visualization tool that was developed by the Institute for Health Metrics and Evaluation to explore different health outcomes of pathogens, infectious syndromes, and antimicrobial resistance across different countries and regions. The estimates that are in this tool are mainly based on the methods that were published by GRAM in Lancet in 2024. And it also shows the burden of AMR in terms of disability-adjusted life years and deaths that are attributable to and associated with AMR. So how to find microbes? So you just go online, go on Google and type microbe IHME. You could also scan the QR code that I've put here. So once you type microbe IHME, it takes you directly to the tool and you can tap and access the data. So to explore data in microbe, let's say you want to compare estimates in different countries, you could use a map. You could also compare estimates across time, let's say from 2000 to 2021 in a particular country using time series plots that are available in the tool. And uncertainty estimates are also included. You could also compare estimates across different age groups, sex, number of deaths across different pathogens, and DALIs across different syndromes. Once you get what you're looking for in the tool, the results are downloadable, and I'll be showing you this in a few minutes. So let's just go straight to Google and type microbe IHME. So this takes you directly to the tool. The tool has 4 tabs. The first one is on key findings. The next one shows infectious syndromes, pathogens, and lastly, antimicrobial resistance. So for the key findings, you can look at them through different locations and different years. So let's say you want to look at a country like Mongolia. So you just select Mongolia, and maybe we wanted to look at estimates in 2015. So you select 2015, and down here, you'll be shown the number of deaths from sepsis, bacteria, and resistance. So as you can see here, from Mongolia, we had around 3,500 deaths to sepsis. And the key terms are also shown in case the terms are confusing. And out of these deaths, around 2,400 were from bacterial infections. And then for resistance, they either show resistance associated with AMR or attributable to AMR. So the number of deaths attributable to AMR are, so for that, the counterfactual is drug-sensitive infections. And for the burden associated with AMR, the counterfactual is no infection. So in Mongolia, you can see those associated with AMR are around 1,500 deaths. So on the next tab, you can look at different infectious syndromes. So still focusing on Mongolia, let's maybe go to 2018. You can see the bar graph shows you the different infectious syndrome, the different number of deaths. So you can choose number of deaths or rate per 100,000. You could also select DALIs if that is what you're interested in. Uncertainty is also shown. So in Mongolia in 2018, for all ages and both sexes, you can see bloodstream infections had the highest number of deaths. For infectious syndromes, you can also use the map, and the map usually shows global estimates. So let's say maybe we want to look at an infectious syndrome like diarrhea, for example, globally for all ages in 2021, let's say. From the map, you can see that India had the highest number of deaths. You could also do trends for the infectious syndromes. And let's say we still want to look at diarrhea. And because we identified India as having the highest burden, we would want to look at the trend in India for all ages. Number of deaths over the years, you can see there's a decline. And if you'd want to look at a particular age, let's say those under 5, you could also still select that to check. Another thing available in the tool are pathogens and their burden. So you could view by pathogen or location, age or sex. So let's say you want to view by location. And then select maybe Staph aureus. All infection syndromes, and we want to view Pakistan, for example. So we'd have to sorry. Yeah, so this is the general trend of deaths caused by Staph aureus in Pakistan for those under the age of 5. And if you'd want to change the age to all ages, you can still do that. If you want to look at dailies, you could also still do that. Then also change it to a rate per 100 per 1,000 or the number, whichever you're looking for. So the last tab is on antimicrobial resistance. So you'd either want to look at the detailed burden, and that would show you a proportion of those susceptible and those resistant to antibiotics. And if you want to look at resistance, it just shows you the dailies and the number of deaths caused by resistance. So let's say we want to look at it globally for all ages, and we want to look at the number of deaths attributable to AMR in 2021. So here you can look at it by syndromes. As you can see, bloodstream infections had the highest number of deaths attributable to bacterial AMR globally. You could also look at it by pathogen. Another thing you could do here is also look at the map. And you can select the antibiotic class you're looking for. So you select the bug and drug combination. So let's say we're looking at Staph aureus, resistance to fluoroquinolones globally. We're looking at the number of deaths attributable to that in, let's say, 2018. Here you can see that the countries most affected were India and China. We could also look at trends. View by bug drug combination, and let's say you want to look at E. coli resistance to third generation cephalosporins. So this is the global trend from 1990 to 2021. And if you'd want to look at a specific country, you could also do that. Say we want to look at Germany, for example, for all the ages. Or Italy for all the ages. You could say in 2020, in 2000, the deaths caused by third-generation cephalosporins resistant E. coli were estimated at around 150. Yeah, so that's all for all the tabs. I'll just be ending by showing you how to download the data. So let's assume you want to download this data here. Number of deaths caused by third-generation cephalosporin-resistant E. coli in Italy for all the ages. You'd come and tap here on download. So before you download the data, you can see here I've logged into my account. You would need to create an account with IHME. And so after registering and creating an account, you can download data. So there's data available from 1990 to 2021, and then there's also forecasted data to 2050. Let's say we're interested in what we are seeing in the graph here. What you do is just tap on the download, and once you download, here is what the data looks like. It's Italy, all ages, both sexes, number of deaths, attributable to third-generation cephalosporin resistance E. coli from 1990 to around 2021. So you have the number of deaths and the upper and lower credible intervals. Thank you. I'll hand over to the chair.
Thank you so much, Rachel. What a great presentation. Just a quick reminder for everyone having questions about the presentations themselves, please post them on the Q&A box and not on the chat so that they can be answered by our panelists as we go. Otherwise, they can be reviewed at the end of the session during the Q&A. I'm handing over now to Dr. Esther Van Cliff. She will be continuing with the WHO class data. Esther, whenever you're ready.
Isabella, are you seeing my slides?
I am.
Okay, great. Yes, welcome everyone, and it's great to see such a big group of people present. Just a disclaimer, what I'll be presenting today is a very broad brush overview of the global antimicrobial resistance surveillance system that is hosted by WHO, and some further resources where Oxford as a collaborating center is involved in. And obviously, in the panel discussion, happy to take any questions. Just so you know, all the views or opinions that I might be expressing today are my own and not of the World Health Organization. I'm currently a full-time employee at Oxford and have been before a consultant with the World Health Organization. So just to start off with, what is actually the main purpose of why we're doing global surveillance of antimicrobial resistance, and what are the main objectives that have been formulated by WHO for GLASS? First of all, what it aims to do is not only monitor the global AMR trends, but also to foster further development of national surveillance systems and make sure that they're standardized, so the data that we use is also comparable. At the same time, once we do a good job in monitoring these trends, we're also better in seeing whatever we're trying to do to mitigate AMR, are we being successful both on a national and on a global scale? At the same time, there's also some initiatives to detect new emergence of AMR early. At the same time, also to see trends in existing AMR strains and or bacteria. And finally, if we have good data, the idea is also that we're able to get a good sense of what is the actual burden of AMR. And there, for example, think about the UNGA targets that have been recently set by the different member states, where we can think of, okay, if we want to really reduce AMR, attributable AMR with 10%, we need to also be able to monitor it properly. And that means that GLAS also has different components, which are all listed here, for which guidance documents are available. I won't be talking about them all. The ones I'll be mainly talking about are the ones here concerning the routine surveillance, or that is part of GLAS, as well as the more enhanced surveillance, which are the national surveys, which have recently been introduced in a few countries where routine surveillance is challenging. Now, what is being monitored in GLAS? Down here, you see the updated number of pathogens that are now part of GLAS, which are a total of 13 different bacteria. The ones in purple are the new ones, which are not yet featuring in the latest 20, as well as 6 different syndromes that data is being collected on. In the latest 2025 reports, these syndromes are blood, urine, stool, as well as urogenital infections, so gonorrhea, which means that in the latest report, there are 93 infection type, pathogen, and antibiotic combinations, whilst in future reports, this will be extended with these different pathogens over here. If you want to go to the latest report, here's also the QR code, and I believe the slides are shared. Now, how GLAS ideally likes to think about the countries that report to GLAS is that they have they have 5 different core components of a national AMR surveillance system, where ideally there's a national coordinating center, where all the different surveillance sites, which could be where the one surveillance site could but might not, but could be assigned by the government, as well as multiple surveillance sites which are happy to participate. And these different surveillance sites, they report on the clinical isolates that are being tested, and some basic demographic data like age and sex, as well as infection origin. So whether it was an inpatient or an outpatient that we're talking about, so in the community and or healthcare setting. And at the same time, there's also some components that concern the quality of the lab testing being done. So ideally, there's a national reference laboratory which is adhering to certain quality standards, as well as that all the different surveillance sites are also following AST guidance that are internationally recognized. Now, not all of the countries that are currently participating in GLAS are adhering to these 5 different core components, and in the latest report you can see the frequency of the adherence. Oh, I'm going too fast. But to go a bit deeper in what is being collected in GLAS and what is basically the type of data we're talking about. So I was already talking about the isolates being reported. So basically, what you can think of is that there's isolate-based data as well as sample-based data. So on the right, you see kind of like the patient populations that are intended to be part of GLAS, and ideally we do a sample-based approach where all the individuals that have a suspected infection are also being that are being tested, but then also being reported in GLAS. Now, in practice, what happens is that because countries can choose, in practice, it's more the isolate-based data that is being reported. So those ones that have a sample that is positive for the pathogens reported to GLAS, that we also know what their resistance pattern was. So what we can do with that is that we can get an AMR prevalence. And I'm saying prevalence because it's basically the proportion of resistance in those isolates that are being reported. Now, with the sample-based surveillance, ideally you have everyone, so all the suspected cases, including those which don't have an infection, a bacterial growth, and with that you would have a good denominator also. So in addition to AMR prevalence, you're also able to report AMR infection incidence, which currently is at the moment challenging with GLAS data. Now, there are some countries which have no routine AMR surveillance data in place. So what what WHO has said in their latest manuals, that they're going for the two-pronged approach, where they're trying to see, can we in those places maybe recommend national surveys? And then with those surveys have a very comprehensive idea of all the patients which come in the clinic, do a cross-sectional prospective study, and then report on all those that have a suspected infection, to then also see, can we come up with further estimates, because we're also collecting data on mortality and a couple of additional components, which could then feed into burden estimates. All this is ongoing and also being evaluated, also in terms of cost effectiveness, etc. But just that it is out there. Now, what I mainly wanted to bring across with this talk is also that we need to be mindful of what is in GLASS and can we take it for face value. So currently, the number of countries that are participating, so that have basically provided data in 2023 is 104 countries. And just to say, 2023 is the latest data that is publicly available, which is reported by 104 countries, so around 71% of the world population. And that means that they at least report on one infection type. And over here, you see then the geographical distribution of those countries. And up at the right, so what we did for the first time in the WHO GLASS report 2025 is that we also reported regional estimates, and with that also regional participation. And over here, from a kind of percentage point of view, you can see that the region of the Americas has the lowest participation from the number of member states, around 20%. Whilst actually, if you look over here, around more than 50% of the African countries are participating. But again, it doesn't mean that they're reporting on all the syndromes, and it doesn't mean that they're reporting on all the different drug-bug combinations. But just to kind of emphasize that there is a disparity between regions as well as countries in terms of reporting. And you could be reporting data, but then there could still be a difference in coverage of those data. And here, surveillance coverage is defined as the number of reported infections with an AST, so with an antimicrobiome, divided by the total population, which could not necessarily be the population that is also having a suspected infection, but it's kind of like an approximation of surveillance coverage. And there you see that, so between 2016 and 2023, about 24 million AST results are reported. And in the latest report for 2023 data, you see, again, geographical disparities. And part of the difference in surveillance coverage could be also because there are country-specific characteristics, so age and sex might differ, as well as that there might be unequal access to surveillance infrastructure as well as lab capacity. And what we've looked at, and what we do know also, among others, by studies from Cherry Ling, is that the number of tests, or the testing rate, is actually associated also with the proportion of infections that are resistant. And it could in part be because probably the higher testing rate is present in those high income countries where AMR is lower. But at the same time, it could also be because those ones who are tested are basically the more severe cases where AMR is more likely. But the main thing to bring across is data is not necessarily comparable, even though the methods are standardized within GLASS, are not necessarily comparable, with a variation in coverage, representative, and selection bias. Now, to kind of start to wrap up, so what are kind of the initiatives that are being done to strengthen routine AMR surveillance? Well, in the latest reports, thanks to modeling approach, we try to at least account in part both for age and sex differences, as well as for differences in testing coverage, to then be able to do more comparable reporting on temporal and yearly trends between countries as well as regions. But also, I was already showing the GLASS manual for 2023, and there actually the reports are now, so countries are now allowed to not only report aggregated data, but also individual level data. And with that, it's also easier to include certain denominators, because there's just a lot more detail available on those ones being tested. At the same time, there's the different survey approaches that are now being recommended and that are being piloted, and further metadata to get a further handle on, okay, what is the number of patients in the facilities, who are the facilities that are reporting, because all this is currently not in detail available within GLASS. And then finally, some initiatives that Oxford is involved in. So in the group of Koen Pauwels, what is also being done is trying to see, can we come up with an optimal sample design, accounting for basically the number of, or trying to see, okay, what is actually the minimum number of hospitals and or patients that are needed to come up with a representative sample of, or to come up with a representative reporting on AMR in a particular country, trying to account for variation in AMR rates due to hospital level and population level variation. And finally, what Oxford is also a collaborating center. So with David Arnesen largely in the lead, we've also been in that sense helping to develop guidance for the whole genome sequencing and incorporating that within GLASS. And I'd also recommend you to have a look at AMR Watch, which is one of the initiatives that is hosted by Oxford and reporting on the openly available sequencing data around AMR. Some final references, and I'm happy to take questions during the panel.
Thank you so much, Esther. Bardi, if you want to go ahead, the next bit of the webinar will cover the AMR Data Repository presented by Dr. Barney McManigal. Thank you. Barney, handing over to you.
Okay, I think I'm unmuted and you can see my slides. Thank you, Isabella, and thanks to Rachel and Esther, and hello to everyone. We've heard about some really valuable tools to visualize and calculate antimicrobial resistance. I'm now going to talk about a resource that can help researchers to go deeper into their own investigations of AMR. I'm going to talk about the AMR Data Repository and what it is and why it exists and how you can use it, both as a researcher looking for AMR data, but also as someone who might eventually have relevant AMR data that can be contributed. So I've been with GRAM since 2018, leading on communications and engagement, particularly with regard to data. As you may know, GRAM was created by health leaders to estimate global AMR burden with the aim of making drug resistance measurable and comparable to other forms of health loss. So as you can imagine, data is absolutely critical to GRAM's work, and we would not be able to carry out our research without our dedicated data contributing collaborators. So what kind of data does GRAM need to estimate AMR? In addition to AMR literature reviews and IHME's extensive resources from the GBD, one thing we absolutely need to estimate AMR burden is individual patient data. This is data is routinely routine patient level microbiology results, where antimicrobial susceptibility testing has been performed. And ideally, we need this data with outcomes, especially mortality status. As a caveat, non-patient level microbiology data that has been aggregated is still very useful. And it's also helpful to have antimicrobial use data and other data types. But we really, really need patient level AMR data to estimate AMR burden. You know, when we first started work, we had very little AMR data, so it was unclear whether we would even be able to estimate AMR burden. But in a major push, 5 senior level investigators and 2 other staff members were able to secure enough data to estimate AMR burden in a single year, publishing in 2022. And then 2 years later, we produced the time series estimating AMR from 1990 to the present, with a forecast to 2050. We were very pleased to reach that point, of course, but that doesn't mean our work was done or couldn't be optimized further. As you can imagine, there are many challenges to collecting patient-level AMR data, including those relating to patient privacy and academic strategy. Another challenge is equity, since data often originate in LMICs, where many researchers lack access to similar data. The map at bottom shows where we have isolate data on the prevalence of resistance and how much. The truth is we need more. We need more data to improve our models. So after estimating AMR burden, we've continued to optimize our practices, not only with data collection, but making progress on equity to make data more widely available in line with what many funders are now encouraging. To help us here, we've joined with our Oxford colleagues at the Infectious Diseases Data Observatory, or IDDO. IDDO is a research organization that has become a leader in data storage, curation, and reuse, hosting data repositories for multiple diseases, including malaria and Ebola. So IDDO has spent years thinking through the complexities of ethical data sharing, and they've developed an agreement called the Terms of Submission, which addresses all of the main legal challenges that we were encountering at GRAM. IDDO allows researchers to apply to use data and provides an independent data access committee aligned with the WHO to make decisions about who can use it, or if the data contributors prefer it, the data contributor can retain that decision-making role. And so in order to make resistance data more widely available, GRAM and IDDO launched the AMR Data Repository in 2024 with the aim to curate and store GRAM's current and future AMR data holdings. The repository now holds data from more than 250,000 patients spread across 69 countries, and that includes 54 LMICs, and the number of patients in the database grows larger every week. There are data sets covered by IDDO's Terms of Submission, 38 data sets covered, and they're all in the repository. The bulk of these 38 have been curated, meaning they're ready now, and the rest will be curated as soon as possible within the coming months. The map shows the spread of the data in the repository. The darker the color, the greater the concentration of data. We have data from single health facilities and single areas, like the data received from the Kumasi Center for Collaborative Research in Kumasi, Ghana. And we have data sets representing patients from across the country, like the data from Aga Khan University in Karachi, Pakistan. The repository holds data sets that focus on hospital-acquired infections, like the multi-country data set shared by INIC, the International Nosocomial Infection Control Consortium. And we have data sets that prioritize community-acquired infections, like the multi-country ACORN study, which is the Wellcome-funded project that stands for a clinically oriented antimicrobial resistance surveillance network. Taking a closer look at the data, tracking the 250,000 patients by age, the largest single group is neonates, followed by 1 to 4-year-olds, followed by 5 to 14-year-olds. The countries from which we have the most data at the moment are Cambodia, Central African Republic, India, Laos, and Iran. And breaking down patients by sex, as you can see that 54% of the patients are male and 46% are female. And here is a further look at total samples in the repository. The greatest number of samples come from the year 2023, followed by 2024, and then 2021. Our leading pathogens are E. coli, Staph aureus, Cleb pneumo, Acinetobacter, and Pseudomonas. And blood cultures form the majority of sample types, followed by urine, sputum, stool, and cerebrospinal fluid. In terms of what you can do with this data, there are many reasons to reuse data sets. By combining scattered data points, it's possible to perform important meta-analyses and increase the statistical power of your findings. Also, the repository has many distinctive qualities which could lead to novel research questions for investigators. For example, a large portion of the data, about 40%, comes from non-blood culture samples, which is unusual. Also, most of the data are from LMICs and contain diagnostic information and patient mortality outcomes, which is also very difficult to find. And about half of patients are under 15 years of age, which reflects the general distribution of the global burden of infectious disease. So if you're interested in applying to use the data, we definitely recommend that you visit the IDDO website listed on the screen to get started. You can read about the available data sets and how to request access. Interested parties will complete the application in which you will specify your intended research plan. If IDDO's Data Access Committee or the data contributor approves your application, you will sign an agreement which allows you to hold the data for a fixed period of time so that you can complete your project. So those are some of the details about using the data. I also wanted to discuss why researchers might want to share data themselves if you are ever in a position to do so. Firstly, funders are increasingly urging grantees to make their data available. So you'll find that sharing data is something that can improve your chances of getting funded. And in addition to expanding data access in parts of the world where data are scarce, as mentioned earlier, reusing data ensures that investigators really get the most out of their data and in a way that is beneficial. IDDO curated data sets are collected according to FAIR principles. They are findable and they come with documentation, with each data set assigned a DOI number that will appear in corresponding publications that use that data set. Further, IDDO encourages data applicants to invite the original contributor to be involved in the proposed research. So for interested data contributors, this is a great way to expand your research output. So that's a brief overview of what the repository is, what's in it, and how you can use it to advance your work on AMR. If you have any questions, please review our information online and do get in touch. Thank you, and I'll now hand back to our chair.
Thank you very much, Barney. And now we will move over to the AMR R package presented by Anna Nevikova. Anna, whenever you're ready, go ahead.
Thank you very much, Isabella. Can I just check that everyone can see my screen at this point in time? Can you see that, Isabella?
I can, yes.
Fantastic, thank you. Well, thank you very much for joining us here today. I appreciate time is a bit short, so I will jump straight into our topic today and the objectives, which are to introduce the AMR software package for working with AMR, so antimicrobial resistance data. To demonstrate some of key package features with code examples, we're working to make these slides available after the talk so that you can work through these examples in your own time. To highlight extensions, as we will not have time to cover everything, and further resources for your own use. And to focus mostly on implementation. This will not be a methods or theory talk, and ultimately whether some of these methods apply to your dataset or your particular analysis will be up to you. A few preliminaries. The package does rely on the R statistical programming language behind the scenes, and links to these resources, by the way, should be in the chat right now or being deposited there shortly. And when working with R, it is particularly useful to use the RStudio integrated development environment. This is a set of graphical user interfaces that will make working with R scripts and accessory functionalities more user-friendly. The base R language can be extended with various so-called packages, which are groups of functionalities or software. And the AMR package is one such package. Some other packages that I will be using in the presentation, which are by no means obligatory, they're purely optional, are representatives of the tidyverse set of packages, specifically ggplot2 for plotting, and tidyr and dplotr for transforming and shaping data. We appreciate many of you may not have used R before or be familiar with it, or indeed used any programming languages. We highly recommend you give it a go, purely because it will empower you to make your analyses that much more flexible and will really let you progress beyond set statistical software or even Excel. And we've linked some beginner resources to get you started, provided by the RStudio team. And finally, for completeness sake, these slides were prepared in the Reveal.js format with the Quarter publication system. So to get back to basics, what is the AMR package? Well, it's a package that arose out of the PhD work of two students at the University of Groningen, Matthijs Berends and Christian Luz, but the team is now a multinational team of collaborators, and the package is being updated continually. It is very much a living piece of software. It is a suite of R tools and also references for standardized, robust, and reproducible antimicrobial data analysis. And it's free, open source, and licensed for personal and commercial use under the general public license version 2. There are a few key exceptions to that license that I will highlight as we go through the slides. Finally, it is now available in Python. I will not be covering the Python version. Just suffice to say that behind the scenes, it is relying on the R package, so you will need to install the R language anyway. And knowing how the R package version works will help you get started with the Python version too. Now, in this talk specifically, we will use a simulated dataset to do a few things. We will first use it to clean antimicrobial and microorganism names using standardized taxonomies and antimicrobial references, interpret some MIC values to SRR categories, create an antibiogram, and show you how to also, if you want to, derive counts and proportions of SRR interpretation categories, and plot an antibiogram. To do our analysis, we'll need some example data. Here's some I took the liberty of preparing earlier. Now, this is the code for that data. And again, you can get the slides later and you can see how it's generated. This is all random data, so it will not be completely clinically accurate, and we're not aiming for that. And I've also in this code included some helpful tips for how to install packages, import them into your session, and also how to access additional help from the console when you start working with R if you're not familiar with it. Now, the actual data itself, let's pretend for a second that we didn't simulate this data. We got it from a collaborator, and it arrived as data.csv, and we wanted to import it into our session. We would do this using this read.csv function, and we'd assign it using an arrow operator to this data object. You would remove that hash symbol, by the way, to actually run this line. This is just commented out here. Then we can view the first 6 rows of this data by calling head. And we can see it's a long data format. There's a column for patient ID, PID, one for lock, so perhaps a study center, bacteria, antibiotic, and MIC values. We can examine the structure of this data a bit more closely by calling str, structure. And we see that we have 400 observations. Here the columns are demonstrated horizontally. And finally, I mean, there are many more things you may want to do, but one thing you could do is examine the case counts for each combination of bacterium and antibiotic in your data set. So you'd select the bacterium and antibiotic columns, and you call table to get a count table. And this is what that looks like. So we can see that we have several categories or several combinations that have no counts. So this will be, for example, for erythromycin E. coli, that would be expected. But also we can see some problems here. So for example, E. coli and Streptococcus pneumoniae, the two bacteria in our dataset, are not coded in a standard way. They're sort of coded differently. The antibiotics are purely abbreviations, and really the whole dataset setup is very unhelpful when working with it. It's long, so we want to maybe turn it into a wide format, making sure that each patient is one row and all the antibiotics are columns. And these MIC values, we really want to interpret them before we can conduct further analyses. So we can do that step by step, and we can now start with cleaning the microorganisms. Within the package, you have several functions for doing this. So for example, the as.mo function can take character arguments, so let's say our abbreviation for our bacteria, and return a package code for the microorganism. We'll show you what that looks like in a second. And then once you have that code, you can use the mo underscore some property function. So here the asterisk can be replaced by a property such as order, genus, is intrinsic resistant, etc. And there are many more properties in the manual, which should have been linked already in the chat. And to give you an example of what using these functions would look like, we can apply these to our data. So we can take the bacteria column. Here we take the data bacteria column, we pass it to the asmo function, and we create a new column called mo. So mo for microorganism. And then we may want to review the process, the output of this procedure. We select unique combinations of bacteria and microorganism, and we use this mo full name function to basically check what the full name of that code, that microorganism code we just assigned is, to confirm this all makes sense. And we can see here that for all the microorganisms, all the code assignments were sensible and correct. If they weren't, you could troubleshoot this by running the mo uncertainties function after you've done the assignment. And here I can demonstrate what the output of that will look like. What it will do is for each unique input to it, so each unique bacterium in our dataset, It gives you a matching score. It has a matching score it uses behind the scenes. Again, details are in the manual for the package. For example, for S-pneumo, it correctly assigns Streptococcus pneumoniae with a matching score of 0.667, and the closest runner-up was Streptococcus pseudopneumoniae, and so on for all the bacteria or bacterial abbreviations in our original dataset. Here, however, we're happy with the assignments, so we can proceed to cleaning the antimicrobials. Similar setup here. The as-AB function takes a character argument and returns a three-letter antimicrobial abbreviation. And the AB underscore some property function can then be used to query antimicrobial properties. So things like trade names, defined daily doses, LOINC, and ATC codes. Again, there's also an antiviral equivalence, but we won't be using that here today. So once again, we create a new column, AB for antibiotic. We use the output of the as-AB function with our antibiotic column to create this column. And we can review the unique output. So here, the unique combinations of antibiotic in our original dataset, the AB column we've just created, and AB name. So that's the drug name. So this is one of these property functions. And the output looks like this. And again, we can see that all the assignments were sensible. Comox became amoxicillin clavulanic acid, and all the way down to penicillin becoming benzyl penicillin, which is what we intended. Now we can proceed on to interpretation. Some more functions for you. I appreciate these are coming thick and fast. The as-MIC function takes either a number or character MIC value and converts it to a clean ordered factor. So what that means is the final result can only take certain values, these being the dilutions, and they're ordered in order of the dilutions. So the program automatically knows which order these come in, which is high and which is lower. You can then pass the output of as.mic to as.sir, and also you need to provide a microorganism name, the antimicrobial, and the breakpoint guidance for this. And that's will interpret these to SIR, this information to SIR categories. An example workflow using these functions may look something like this. Here, in the first step, we overwrite the MIC column using the as-MIC function to produce a cleaned MIC column. We then use a tidyr function called pivot wider. If you've worked with pivot tables in Excel, and if you've not worked with R before but have worked with pivot tables in Excel, this does something analogous to that. Basically, what it does is it takes the MIC column and pivots it so it's horizontal. And so each patient has one row, and each antibiotic has one column, and the isolate and patient results for that particular isolate patient will be in the cell corresponding to the antibiotic. This means that there'll be a column for each antibiotic in the data set, that even if it wasn't tested for that particular isolate, and we'll see that in a second. Finally, we can pass that entire data set we just created, because we overwrote it in the previous step, to the as-SIR function. We tell it which column to find the microorganism code in, so the MO column, which guideline to use, UCAS 2025. We specify that none of these samples are UTIs, let's pretend that for now. And we have our own reference data set here that we use for the breakpoints. Now, the package does come with its own breakpoint references, so there's no need to do this. I'm just doing this here for convenience. Finally, we view the results of our outputs. And this looks something like this. So we can see this is now a nice wide data table. Each patient has one row. And if a particular drug was tested for that patient, there will be an interpretation in that cell. If not, there will be an ANA, which means not available. Now, in this instance, these combinations are not available because we didn't actually generate any data for those combinations. But in the real world, you may get a data set where a drug could have been tested for that combination, but it wasn't for whatever reason. Or you may just be wondering if there's an evidence-based way to infer some of these missing values. Now, something you could do, and you will have to decide whether this is advisable for your dataset, is apply ucast rules to your dataset using the ucast rules function. When we say ucast rules, we mean one of several things. We can mean the guidance in the breakpoint tables, we can mean the expert rules, expected resistances, and also exceptional phenotypes. You can also define custom rules to apply with this function. Depending on which rule you define, they may not be ucast rules as such anymore. So it's a bit of a misnomer, but again, you can do that and then you apply them via the ucast rules function. And I would recommend you review the manual for how to do this if this is something you're interested in. So if we just attempt to apply this function to our data set, and we tell it specifically we want the rules to be applied to be breakpoints, expected phenotypes, and expert rules. This is what the output will look like. So here, for example, ceftazidime and gentamicin for Streptococcus pneumoniae are resistant because that's an expected resistance phenotype. And the Comox column has been inferred. But if you want more, that's quite, obtuse. You're not quite sure what's going on behind the scenes. If you want more information, you can run the function again, but set info equals true, and it will provide a very detailed readout of everything it's doing behind the scenes. So here I've done this. I've actually overwritten our data set with the output of ucast rules with this arrow and asked it to give us a more informative output. And it provides a very thorough readout here. Here it tells us in the top part what other drugs it could do with to apply these rules more effectively. And then it gives you a readout for each rule set. So here we see the clinical breakpoint table rules, and we can see where the changes were made. So here 50 were added, 8 values were changed. Resistant phenotype rules, again, which ones were changed and which were not. And finally, the intrinsic resistance rules. If you scroll right to the bottom, it will give you a readout of all the changes that were made. Here, results were added, but no results were overwritten. This is per UCAST suggestions that if results were reported, they should be reported. So you can change this behavior. You can ask the function to overwrite your results, but this is just simply not recommended. And again, I will leave you to decide whether this is appropriate for your data set. We don't have time to cover everything, so here's some data cleaning extensions for you to explore in your own time. The package provides several antibiotic selector functions which can let you filter rows or columns based on antibiotic classes and subclasses in some cases. For example, here I've used the penicillin selector with our data and asked it to look for only resistant results. What this means is that it will only return rows in our data where all the penicillins are resistant or are interpreted to be resistant. And we'll look at the first 5 rows of this function if we perform this operation. And we can see that indeed all the rows that are returned have both benzyl penicillin and ampicillin as resistant. Then we can use first isolate and filter first isolate to identify and filter, respectively, first isolates based on one of 4 definitions, whether it's isolate, patient, episode, or phenotype based. You can also access the reference data sets that the package is using behind the scenes to perform all these operations, be it taxonomic assignment or identification of antimicrobials. It's relying on references it's imported itself. And these can be, again, accessed in the package by calling the names in the consoles or in your session, or directly from the package website. I believe the link for the dataset should have been, again, inserted in the chat now. Just be aware, if you're using the datasets themselves, there's some slightly different licensing conditions that apply in some cases. For any WHO-CC sourced antimicrobial names, defined databases, and ATC codes, these are not licensed for commercial use. That may not apply to most of you, but just something to be aware of, and just check when you use the datasets. Now we've got our dataset, and we wish to now to generate some descriptive analyses, basic descriptive summaries. There are a few convenience functions in the package for doing so. For example, resistance, susceptibility, and proportion underscore an SIR category to calculate proportions. The susceptibility function by default lumps together the SI and SDD categories, and resistance returns a proportion of the R category only. However, if you wanted to modulate that, you could use the proportion underscore and an SIR category, for example, proportion S for S only, and proportion IR for intermediate and resistant only. Again, depending on which guideline you're using and which definition you adhere to. These can accept multiple result sets and return combination proportions as well. Or you can generate a data frame, so DF, or basically a data table using proportion underscore DF or SIR underscore DF. The difference between these is SIR underscore DF also returns case counts in brackets to return a data frame with a calculated proportion for all categories. And you can calculate exact binomial confidence intervals using this SIR confidence interval function. Now, you can, of course, combine these to then perform more complex analyses and generate antibiograms, but obviously this will be a bit laborious and maybe a bit prone to user error. So the package does provide us an antibiograms function, which is antibiogram, as you may have guessed. And you can use this to generate traditional syndromic combined or Bayesian whisker, so weighted incidence syndromic combination antibiograms. And finally, you can plot the results using base R plot or bar plot functions, or as we'll do here, the ggplot to autoplot function. So just a reminder what our data looks like at this point after we've applied all our transformation and UCAST rules to it. If we just pass this dataset to the antibiogram function, it will split the dataset by the 2 pathogens we have in it, but it will return results for all the antimicrobials singly, and it will not split by a location, which maybe is something that we want. So we can do better than that. If we want to generate something like this, we would, and I will walk you step by step through this function, we will do this function call. We can first of all filter our data set on using one of these MO property functions, MO genus, for the genus Escherichia. So now we will only get E. coli in our results. We ask it to return results for Kermox, gentamicin, and the combination of the two using this plus operator, and to only return results for isolates where both of those were tested. So only all tested equals true. We can then maybe say, depending on which, again, guideline you're working for and which guidance you use, we perhaps want only the susceptibility and not the intermediate category, or again, increased exposure, depends which guideline you use. So we say combined SI equals false. We want to split our results by location, so we can slightly abuse the syndromic group argument to parse at the location column. And we want these results to be only calculated if there's a minimum of 10 observations in each category of location, bacterium, and antimicrobial or antimicrobial combination. So minimum is equal 10. Finally, we just set some formatting arguments. Here we ask to use the full name of the pathogen, but only the abbreviation of the antimicrobial. And this is the output we get. But we can also plot this output very quickly and very easily using the autoplot function from ggplot2. And I've just applied a simple black and white theme. And just with that, we already have quite a nice graphed output. The confidence intervals here are these exact binomial confidence intervals. For this particular type of antibiogram, it will be exact binomial confidence intervals. A word of caution is that these are for each proportion singly, so they may not be suitable for cross-category hypothesis testing. It does really depend on which question you're asking, just to keep in mind, because displaying them like this slightly tempts the eye to make comparisons. Again, we won't have time to cover everything, so hopefully a link to the manual has been provided in the chat, and the manual has some very helpful tutorials on a number of extensions to our analyses today. So for example, you can plot MIC and SIR values, and they walk you through that process. There's a tutorial on working with WhoNet data, if this is something you do on a regular basis. There's a tutorial on identifying multi-drug resistant isolates, on performing principal component analysis, on resistance components, on integrating these functions we've learned about here today into a basic machine modeling workflow with the tidy models set of packages, and really many more convenience and quality of life functionalities, such as setting output languages. There are currently 28 in the package for output plots and tables, saving custom package settings if you're working on a particular project over a long period of time, just so that you can have those settings re-imported in, time out. And again, many other things we have not had time to explore. So I appreciate that was very quick. There's a lot. We're hoping to make these slides available to you so you can go through all the examples and the links and the slides in your own time. Also, a word of thank you to our funders, and all the references for the discussion and the talk are on this slide. Thank you very much.
Thank you, Anna. That was an amazing presentation. We will now begin the Q&A session, which will be moderated by Professor Cooper. Ben, if you would like to briefly introduce yourself, I will hand over to you now.
Okay, thank you very much to all the speakers, and thanks, Isabella. So my name is Ben Cooper, and I'll just be leading through the questions here. So we've already been answering a lot of the questions in the Q&A box by text, but we have a bunch of other questions, and I'll just go through those in the orders of the speakers. So starting with, so I think we've got till 11 o'clock, haven't we? So we've got 25 minutes. So starting with Rachel, can anyone download data from MICROBE?
Yes, anyone can download data from MICROBE. You just need to register and show the reason why you want to use the data set. And then once you're registered, you can download the data and use it. Yeah.
Okay, that's great. And this is particularly for late joiners. For someone seeing MICROBE tool for the first time, what are the main insights users can get out of it?
The main insight you can get from MICROBE is the burden of, so burden in terms of deaths and disease associated with different pathogens and antibiotic resistance, yeah, across different countries and regions, yeah.
Okay, that's great. And then there's one final question for you, Rachel, which is, if I want to download data for every country in the world, is there a way to do that? So that's not the kind of combined global estimate they're asking, but for like Afghanistan, Albania, etc.
Yes, there's a way to do that. Maybe I'll just show you. So I hope you can see my screen. So in the tool, let's say you want to look at estimates from different countries in terms of antibiotic resistance. So you'd need to select view by location. Let's say you're looking at Acinetobacter Baumannii and its resistance to aminoglycosides. So if you select view by location, you can select more than one country. So let's say you wanted 5 or more countries. So once you do that and you download, you can see that the data has different countries and not just one of the global estimates.
That's great. Okay, thank you very much, Rachel. Okay, so next bunch of questions are for Esther. Um, so there's a question which is related to the glass. Are there any plans to estimate rates of infection or rates of AMR in addition to proportions?
Yes, well, thanks for that question. So, what currently the latest report also, right, that data is still aggregated data. So so basically the isolates are reported in an aggregate way by certain demographic groups. And as I presented in 2023, the manual is allowing countries to report individual level data. And with that, also countries are asked to report more detailed metadata around, among others, the hospital beds per facility, the number of tested individuals, etc. So provided these data is getting more and more complete over the years, the intention is indeed to report rates rather than just proportions, because obviously that's very informative and more informative.
Okay, that's great. And next question, I'm trying to see if this has been answered online in text. I don't think so, though. So the question is, what capacity building support does GLASS offer to countries not yet participating?
That is a question I am afraid I can't answer in detail. I can get back to that question, but not sure.
Okay.
There is capacity building support though, but yeah, not
Okay.
sure.
Okay. And then two more questions, which you may not be able to answer. I'm not sure. Um, um, so, um, so has there been any work to determine what factors and challenges affect countries, what challenges there are in gathering and sharing data for countries where there is a lack of AMR data?
Yes, I think I answered that one already
Oh,
in
did
the
you?
chat.
Okay. Okay.
Yeah, but there is basically there is some form of evaluation of global action plans of
Okay.
countries.
Yeah.
So there countries are also being asked about certain challenges related to capacity and health system challenges, etc. So there is this initiative which tries to gather, where the main
Yeah.
bottlenecks are.
Okay,
Yeah.
that sounds good, and you typed in the answer as well. So,
Mm.
and then final question for you for the moment. There may be more that come later, but will glass data be affected by the US leaving the WHO?
Yeah, I was hoping to not answer that question. I
Right,
think
sorry.
I think this is a political question, right? Which
Well, I don't know. Yeah,
yeah, discussions are ongoing, but yeah,
yeah.
I can't be answering this. Yeah, I'm
Okay,
sorry.
yeah.
Yeah.
You're not the
Mm,
representative of WHO.
mm,
Okay,
mm.
we'll let you off there. Okay, thank you very much, Esther. Next questions are for Barney. There's a few questions about the AMR Data Repository. So let's go through these. First of all, how long will the process take to request data from IDDO?
Well, so I would say that, the repository has an inventory of data sets after, you've reviewed that list and decided, that you want to use a data set. The next step would be to register with IDDO on the IDDO website and then complete the data access application form. And your form will be reviewed by the data access committee or the data contributor. So IDDO estimates that the review takes about 15 days or 3 weeks for the data access committee or the contributor to complete. And then if successful, IDDO will ask you to sign a data use agreement before sending you the data. IDDO advises people to budget at least 2 months from filing your application to receiving data, and the process is free.
Okay, great. Okay, thanks. And Second question is how are original contributors acknowledged in new projects based on shared data?
Yes, that's a really good question. So IDDO encourages applicants to include data contributors in the research. So they that might mean inviting the contributor to participate in a publication. Now, the data contributor is under no obligation to participate. If that's the case, the contributor, the data set will still be listed um, as a DOI in the publication. However, if the data contributor is interested in participating in the research, that could potentially mean joining the authorship if, they meet the requirements of the journal or bodies like the ICMJE.
Okay, that's great. And then a couple more questions. So who can apply to use the repository data, and does that include students?
Absolutely. So IDDO welcomes applications from all qualified researchers, regardless of their credentials. The Data Access Committee will be looking for projects that are achievable and for applicants who have a track record to suggest that they can complete their work successfully. So if you're a more junior researcher, you might want to link with a more established investigator, but this is not required. Uh, I would say if you have questions, you can always direct these to the team at IDDO.
Okay, great. And then, Bunny, I think there's one more question, which is after identifying repository data, I would like to use what is the next step? Can you give some practical guidance on the application process?
Um, well, so I think I already spoke about the how long it takes to do the application. I would say that, the primary audience for the repository at this stage, it's researchers who are working in public health and the medical sciences, including epidemiologists, research doctors, statisticians, data scientists, and this could be people in academia, but also in government and the not-for-profit sector. In terms of use cases, I would say that, it's probably most appropriate for people doing secondary analyses, trends, surveillance, and perhaps methodological improvements.
Okay, that's great. I think that's all the questions we have for the moment, Barney. So thank you very much. And next up are questions are for Anna about the AMR R package. So first up, what clinical breakpoints are available in the package, and can we add to these?
Yes, sure. So the package comes with its own clinical breakpoints reference data frame. These include as defaults the CLSI and the UCAST guidelines for clinical breakpoints from 2011 to 2025, and they've been updated iteratively as more guidelines are released. They also have ECOFs and veterinary cutoffs for, they sort of vary by guideline, but about early 2020s up to 2025. And again, those will be updated. The thing with the package, though, is you can absolutely add your own guidelines if you want. So if they're not included in the package, you can follow the package instructions for preparing a reference table, like we did in one of those examples, that matches the set format of the reference table. So, for example, I think I've seen some people ask about CASFM guidelines. You can just do that. You can prepare the table yourself on your end if you have access to those guidelines and use them with the package.
Okay, that's great. And next question, what types of users do you see benefiting most from the AMR package?
It will really depend on what your position is and what your role is in your organization. Basically, anyone who works with antimicrobial data and just needs to be a bit more flexible in their analyses or just their cleaning. Maybe just the standard software does not really work for their particular purpose, or they just want to have greater control of their data. But this could be analysts, there could be microbiological analysts or microbiology workers wishing to sort of standardize their data better. This could also just be, sort of surveillance teams and the like. It really depends. It's just a suite of tools, and if they don't fit you, there's no obligation to use them.
Okay, that's great. And then there's a few um, more technical questions. So, are there codes for disk diffusion in the package? Or
Yes,
just
sorry.
someone?
So I know I focus on MIC values. You
Yeah.
can interpret disk values.
Okay, cool. And okay, can the distribution of RAM? So and I think, have you answered the question, can CLSI breakpoint guidelines also be used, or only UCAST? I
Yes.
think yes.
So CLSI
Yeah.
guidelines for the years mentioned, so 2011
Yeah.
onwards for clinical and about early 2020s for the rest are
Yeah.
available in the package. You
Yeah.
can, for earlier years, you can add them manually.
Yeah, yeah. And then someone else was asking, how do you know what version of the UCAST rules are applied?
You specify it. You basically can tell. By default, it will apply the latest UCAST. So I think
Yeah.
there's one example where I showed you, I asked it to use the UCAST 2025 rules.
Yeah.
But I mean, again, anything that's available, anything you add, you can just tell it to use that.
Okay. So you can do anything. Yeah. And the final question I have on here, there might be more have come through, but have you ever checked the results of interpretation between the AMR package and WHONET? So someone says, we've already had WHONET available and validated by WHO. So what are the advantages of the AMR package compared to WHONET?
Well, I'll have to throw that question back to the person who asked it. It sort of depends what the advantages are for you. So
Yeah.
if you're working with WHONET daily, day in, day out, and you don't need anything else, then there's no reason not to use WHONET. In terms of comparisons, I've never compared them, but I should say that the reference datasets, if you go on the AMR package manual pages, they will have usually some sources or some sourcing for each dataset. And I've actually gone down the rabbit hole for the clinical breakpoints dataset at one point, and it traces back to I want to say the HUMNet AMRI database, and it's basically built on that. So in a way, these actually sort of link up behind the scenes. I'll let you explore that in your own time. But again, it's sort of, if you use HUMNet in your work and it's serving you fine and you don't need to go beyond that, then there's not necessarily any need to use the MR package.
Okay, that's great. I think that's all the questions for the moment. There might be more because I'm just looking at the open questions. So I'll just go through these.
There
Which
is one, if
Oh,
I
there is
can,
one.
Ben.
Okay, yeah.
There's one on
Okay.
CDISC, so the use of CDISC standardization standards to align collected data.
Okay.
So this is one I'm not quite equipped to answer, but actually IDDO would be. So our colleagues at
Yeah.
IDDO, I know they've discussed or given talks before on the use of CDISC for standardization of antimicrobial resistance data. My understanding is that will be further up the pipeline. So that's once you've cleaned the data, that's when you be using to standardize those various data sets together. So for example, dataset amalgamation. I think, yeah, and I know some of our colleagues have done talks on this. So I think if you go and look at some of the IDDO outputs, they may have a more sort of informed discussion about this than I'm able to provide at the moment.
Okay, that's great. That's very clear. I'll just go through remaining questions which we haven't answered, and throw these out, or I will try and answer some. Someone asked, can micro be used for research projects, or do we need to request permission to use? It absolutely can be used for research projects. You don't need to request permission. You just need to acknowledge the source and the papers it comes from if you're using those numbers. So that's quite easy. Then there's a question for countries with no data, for example. So this is just anyone who wants to answer this can answer it. And for countries with no data, for example, South Sudan, how can a collaboration be made possible in case some researchers or data enthusiastic health professionals / students would love to contribute? Anyone want to answer that? Barney, if you have enthusiastic people with data in South Sudan, how should they get in touch?
Well, it sounds like it would be fantastic to apply for some funding and have a project that could support data collection in the country. And
Hmm.
I mean, I think it's a great idea, but that's about what I would say.
Okay. Okay. So okay, that sounds good. Any other ideas on that? No. Okay. If not,
I mean, there's always, because there is basically
yeah,
I mean, WHO is currently really overstretched, right? But
yeah,
there is always a possibility to reach out actively to WHO and ask them, because they have they have basically country support officers within the AMR team. So it could always be worth sending an email to them and say, are you aware of any other initiatives in this particular case, South Sudan? But
yeah,
that would be as far as I can go from WHO side.
yeah. Okay, sounds good. Okay, it's another question. Can we freely use microbe graphs and information without any data use agreement or any obligations? Um, so perhaps I'll try and answer that. I mean, I think just normal fair use policies kind of apply. So if you're giving a presentation and want to use those graphs, there's nothing to stop you from doing a screen grab and showing them, but just acknowledge the source and acknowledge where it's coming from. Um, and that's fine. And of course, you can download the data, the estimates, and you can use those in publication. There's no data agreements that need to be made, but you just need to acknowledge the source. So that's just like any other academic publication. So basically, you should treat microbe just like any results in an academic publication. You wouldn't reproduce them and pass them off as yourself, but you would sort of acknowledge their sources. So someone else asked, I think IHME platforms have restrictions to the amount of data you can access on its site, especially when you're selecting many options on the selection section of the platform. For example, when you select all available countries, drug by combinations, years, there could be some restrictions. Yeah, that's possible. And I know there have been some changes to the IHME platforms due to issues with sort of large language models scraping everything from them. So, but I don't have precise details on what the current restrictions are, I'm afraid. I'm not sure anyone else can answer that. What next question? Someone said in that case you may need to fill in an application form formally. Yeah, I think that would be a case of contacting IHME if you can't download what you want to. Someone asked on Microbe, how can we download data of 2025? Well, those data aren't on there. There's a few people asked when they get updated. So they get updated when new publications pass peer review and are published. So currently it goes up to 2021 and that will be updated this year. And someone asked, will you be able to share the slides? And it says Isabella is typing an answer. So um, and that should be there. And I think,
I
um,
just wanted to mention that the slides will be available in the TGHN platform link I have just posted.
yeah, okay, that's great. And I think that's all the questions I can see have been answered. I don't know if anyone else has seen other questions that I've missed. No? If not, then can I hand back to you, Isabella, to close?
Of course. Thank you very much. Thank you all for taking the time to answer the questions. We have now then come to the end of the session. Thank you very much for joining, and we hope you enjoy the session. We appreciate your feedback. Here's a link and a QR code if you would like to leave us some feedback. Your input would be very much appreciated to help us improve. And just a quick note, there will be a second session later this afternoon at 3 p.m. UK time in case you would like to share this information or attend again in case some of your questions didn't get answered. Thank you very much for your participation and thank you to all the speakers.